Yeah, I'm ready.
Perfect.
Should we start?
Good morning, good afternoon, good evening, everybody, wherever you are, and welcome to the Global Emergency Care Grand Round. My name is Rihanna, and I am a clinical fellow in emergency medicine working in Bristol, UK. I will be running this session with my colleague Sue. Sue, would you like to introduce yourself?
Hi, I'm Sue. I'm one of the doctors who used to work at BRI-ED. Now I work at Southmead ICU. I will be hosting this grand round with Rihanna today.
Perfect. For those of you new here, Dharura is an organization that supports ethical, sustainable, equal, and reciprocal global emergency care health partnerships. Dharura also supports mutual and global development through sharing knowledge, skills, and innovations for which this global emergency care grand round is developed. We have a wide variety of speakers and topics being shared and discussed each month, with speakers sharing topics across all aspects of emergency care. Sue will now be running us through some ground rules for the session. Over to you, Sue.
So in terms of some house rules, welcome everyone. Please, if we can keep our mics and mics off and cameras on if able. As we go through the talks, if you can post your questions in the chat, if you have any, and there'll be an opportunity at the end of each talk to ask some questions to the speakers. I'll give a speakers 15 minutes heads up in their talks and a 5-minute warning as well. If everyone could use the chat function to post their name, location, role, and email on the chat function, so we could just introduce ourselves. This session will be recorded. It is currently being recorded. If you have any issues with that, please give us a message. Yeah, over to you, Rana.
We would now like to introduce Dr. Luca Blesi, who is our first speaker as well. Luca is an MD in ICU with a master's degree in pediatric ICU as well. He works at the Alessandria Hospital in Italy. He also has extensive experience and has worked with Medicine Sans Frontiers in DRC, Central African Republic, Syria, and Afghanistan. Luca will be discussing about management of burns in low-resource settings today. Thank you for your time, Luca. Now handing over to you.
Hello, everybody. Thank you for the introduction. My name is Luca, and I'm an ICU doctor. At the moment, I work in Italy, and I have also been part of MSF since 2016. I'll be dealing about the challenges of burn management in low resource settings. So working in low resource setting is a constant balancing act. Every day you are negotiating between what you wish you could do and what you can do. You're navigating around the things you don't have, but you're also discovering unexpected strengths. In this session, I want to walk you through some of those struggles and some of those surprises as well. How sometimes when everything you're used to is stripped away, you begin to see what truly matters in care, and how this kind of medicine is about adaptability, purpose, and true intention, and far from being about improvisation. All that I will be dealing with comes from real patients, real teams, and real stories. Let's start with one of the most critical and stressful issues in burn care, the airway management. In high resource settings, we tend to go for early intubation or even tracheotomy when the face is burned. We have ventilators, humidifiers, sedation protocols, and we can keep the patient stable and intubated as long as we need it. But in low resource ICUs, this isn't always an option. Often intubation can only happen in the operating theater. And keeping someone sedated and ventilating in ICU most of the time is not feasible. Not because we don't want to, but because we don't have the gear or the staff skill, or sometimes even a basic humidifier. So what do we do? One option is to elevate the head of the bed to decrease the swelling and to keep a patient MPO without placing a nasogastric tube for at least 48 hours, which is when the peak of facial edema happens. And it's true, it means sacrificing some calorie intake for the first 48 hours, but this no-touch policy is proved to be good, because from that moment on, from after those first 48 hours on, it's downhill. And most importantly, we try to avoid intubation unless it's absolutely necessary. Of course, this way has trade-offs. And yes, on one hand, we avoid ventilator-associated pneumonia, we avoid the hypotension from sedatives, and we don't need tracheostomy care. Plus, we encourage early physiotherapy and mobilization, and that's a win. But on the other hand, pain management becomes harder because patients are awake. Surgeries become more complex because every time we are inducing and extubating. And sudden deterioration is much more dangerous because we are walking a tightrope. About pain control, in low resource settings, we normally don't have dexmedetomidine. And so what we can use is another strategy. Gabapentin and amitriptyline help with the background neuropathic pain, and ketamine and lidocaine infusions help spare opioids. It's not second best, it's what works within the system you've got. In this case, it's hard to tell which approach is the best, comparing high to low resource settings. Next challenge is respiratory failure and ARDS. In high resource settings, you got the whole toolkit: active humidification, protective ventilation, neuromuscular blockade, nitric oxide, esophageal pressure monitoring, Swan-Ganz catheters, ECMO, and so on. Now imagine not having any of those. What do? We turn to awake prone position or lateral positioning, and to decide which one to go, we can guide our decision with the ultrasound. This is only possible if burn allows the most indicated position. So if I have burns involving the chest and the abdomen, it's impossible to put a patient in prone position. Then we rely on oxygen therapy and non-invasive ventilation when it's available. Plus, a slight sedation can help control the respiratory drive and can help keep the transpulmonary pressure in a protective range. Then, reduction of oxygen consumption becomes mandatory, so we fight against fever and shivering. And it's again a trade-off. This strategy as well means less sedation, better hemodynamics, better GI mobility, and easier mobilization. But, and it's a big but this time, it's tough to control respiratory drive. And managing ARDS without a ventilator is incredibly challenging. Plus, if pain isn't well controlled, or if the chest wall is stiff from burns, NIV just doesn't work well. So this time, the winner is clearly the high resource setup. And so we are doing our best with limited tools, but the physiology doesn't always cooperate. Let's talk about hemodynamics. In a modern ICU, you will have central lines, arterial lines, thermodilution system, and a full range of vasoactive drugs. What about low resource settings? Often you just have epinephrine, maybe norepinephrine, but absolutely no dobutamine. Central lines are rare because they are expensive, risky, and they're often discouraged by NGO policies. So we rely on two large bores, peripheral IV, And a good trick is to cannulate the basilic vein under ultrasound guidance using a peripheral cannula. It's stable and it's a very secure IV access. Plus, we monitor the basics: heart rate, capillary refill, mottling skin, urine output, periorbital edema, and we rely on ultrasound. With a good point-of-care ultrasound, you can assess the IVC and calculate the VEXUS score, so the venous excess ultrasound. You can estimate left atrial pressures. You can measure LVOT, VTI, and assess fluid responsiveness. You can get a precise idea of cardiac output and calculate systemic vascular resistance to categorize the different kinds of shock and monitor their trend over time and after treatment. Let me share a case that explains all of this. It's a 45-year-old man, 2 weeks post 55% burn with persistent fever and tachycardia. Cultures came back negative. The ultrasound shows a very high cardiac index, more than 5, and average to high systemic vascular resistance. So a possible diagnosis was hyperdynamic state due to hypermetabolism due to burn, and the possible treatment is beta blocker. It's always tricky to start a beta blocker in a patient that might be hypovolemic or in risk of sepsis, but the data collected with the ultrasound was pretty clear. So we started beta blockers and the symptoms resolved completely and fever resolved as well. We didn't need Swan guns, we needed an insight in this patient hemodynamic, and ultrasound gave us data. Sure, ultrasound has limitations. You need extensive training, good transthoracic windows. You need time and commitment to assess and reassess over and over again. But the gains are enormous. Fewer infections, less iatrogenic anemia, and better decision making. So in this case about hemodynamics, I'm really not that sure which setting is the clear winner. Here's something we don't always appreciate enough: what sedation and intubation steal from our patients. If your patients are sedated, they are not mobilizing. They are at higher risk of pressure sores, ileus, and pneumonia. Then they are psychologically cut off. But in many low resource settings, our patients are awake. They can sit up, they can interact with us and with their family members. They can even walk to the operating theater. They keep their bowel function, and they often need fewer nursing intervention. They can even go to the toilet on their own. And of course, that comes at a price, which is mainly in the complexity of pain control strategies and surgical logistics. But again, it all comes down to time and commitment. You need to be there and supervise nursing, procedures, and physiotherapy sessions so that you can titrate analgesia to prevent procedural pain to arise. But from a recovering human dignity perspective, it's a real game changer. And I think that in this case, we have another win for low resource. Now, let's face the daily enemy, burn sepsis. In high resource settings, we have cultures, CRP, PCT trends, rapid PCR, imaging, third and fourth line antibiotics. What about low resource settings? Well, often no cultures are available, or if you're lucky enough to have a micro lab, you probably get delayed results. There's no molecular PCR rapid diagnostics. Labs can only provide CBC and CRP. There's no PCT, no serum albumin level monitoring. And talking about albumin, just forget albumin infusions. The only thing you can do is to get plasma from whole blood sedimentation, which is a time-consuming and really wasteful procedure, that will burn through your blood supply. Plus, MDR and XDR organisms are really widespread in the community. And the reason is that there's a massive antibiotic misuse, and you will see that everyone takes ceftriaxone and amoxiclavulanate for every kind of medical condition. And what about second and third line antibiotics? Well, most of the time they are out of stock or not even available. So what do? We normally treat empirically according to protocols, or we target the result of the microlab if we have one, and if we have the right antibiotic available at hand. So while sometimes we just have to deal with the frustration of running out of option because we have no other choice. And so the winner in between the two settings is pretty clear and pretty obvious here. Now, imagine your patient doesn't even get to you in time. That's the reality. There's no ambulances, normally no private cars, and roads are so bad that 50 kilometers can take up to 7 hours to go. Plus, burns are often initially treated by traditional healers. Wounds are contaminated or tightly wrapped, causing ischemia and compartment syndrome. These delays increase mortality, infection risks, and reduce surgical options. This isn't just about medicine, it's about access. What happens when it's finally time to operate? Well, in high resource centers, you got dermal substitutes, skin banks, plenty of resources, while in low resource hospitals, you might have some mesh grafting, but you know that mesh grafts only work if you have enough healthy skin to harvest from. Then you might have a couple of mesh machines for much more than just a couple of patients, plus normally a single autoclave, meaning long waits between surgeries. How can you overcome this disproportion? You can do it with a thorough organization of OT list and a really tight schedule in OT. It's hard for the team, for the patient, but it's the only way forward. But anyway, I can guarantee that you'll be amazed by how remarkably the skin can heal, especially in children. If there is one hero in all of this, it's ultrasound. It's portable, reusable, and multifunctional. It becomes your hemodynamic monitor, allowing you to assess cardiac output, systemic vascular resistance, fluid tolerance, and fluid responsiveness. It will be your lung imaging tool, your line placement guide, your deep venous thrombosis screener, your abdominal exam. You can assess GI mobility and GI swelling for fluid overload. You will be able to assess renal perfusion and renal edema. And it will be even a tool to infer intra-abdominal pressure to rule out abdominal compartment syndrome. In low resource setting, ultrasound is not a luxury, it's a gold standard. And if you learn how to use it well, it will make a real difference. So here's the final point I want to make. Low resource does not mean low quality. It means delivering the highest possible standard of care using the tools, time, and people you actually have. It means committing to safety, dignity, and human connection, even when your environment seems to strip you of the basics. In fact, it forces you to re-examine your practice. What really makes a difference? What is just routine? And what is actually getting in the way? Yes, some tools are irreplaceable, no doubts about it. But what about other tools? Some of them have just become some comfort blankets for us. We use them out of habit or fear or because the system tells us to. And sometimes not having them gives us clarity. Now, I didn't give you formulas or guidelines, how much ringers for a 3-year-old with 20% TBSA burns, or the protein intake for a 54-year-old on day 4 post-burn. Instead, I decided to use this time to give you a feel for the real struggles of burn care in low resource settings. But for the technical details, which are absolutely paramount, by the way, I've trained a custom chat tool with verified sources and guidelines. And you can ask it things like, give me a full 48-hour plan for a 2-year-old girl with 15% burn, and it will make it for you. Or what's the treatment for itching during burn recovery? Or how do I manage burn caused by white phosphorus? You will get certified answers for that. Just scan the QR code and try it out. It provides a good, solid starting point to start treating your patients. And yet, despite all of this, burn patients often offer the biggest rewards. They ask for everything: weeks or even months of dressing changes, tailored nutrition strategies, long-term physiotherapy, multiple surgeries. They occupy the few operating theater slots that you have. They stretch your logistics, your drug supplies, your patience, most of all. They demand an enormous collective effort from the entire team, but they also give back in ways that go beyond medicine. They force you to be inventive. They connect you with the core of why you chose this job in the first place. You will witness their pain, complaints, and moods, yes, but you will also witness their resilience, their trust, and their transformation. And then one day, they walk, they smile again, and you realize that this is what it was all worth it. So thank you for your attention. And if you want to ask me anything, I'm available and open to any question.
Thank you so much, Luca. A very grounding presentation to remind us about the privileges we have in tertiary care. Anyone, if you have any questions, feel free to unmute or just pop it into the chat. We have a question. Hi, Shubham. We have a question. How do you approach to planning and preparing for triage in the event of a mass casualty incident involving burns patients?
Like all the other, thank you for the question. And you know, it's a very common situation, because when there is an explosion, you will have by definition many burn patients coming in at the same time. And one of the first things you have to study when you set foot in a new mission is the mass casualty plan. Every mission has one. You have action cards. You will know what to do, how to set up a reverse triage from the ER up to the ICU and up to the department. And so you just follow the rules. And the most challenging thing is that you know that you will really strain the logistics of the project. So the consumption of bandages, or sulfasalazine cream, or antibiotics, ringer, and everything else will go up, will skyrocket. And so you need to prepare the whole team. But you will have very clear instruction and very clear protocols to follow.
Okay. Thank you so much, Luca. Any more questions, please feel free to pop it in the chat and we'll be able to share it with Luca and then get back to you if it's okay. Now I'll hand over to Sue to introduce our next speaker.
I think there's one other question as to whether the slides could be shared. Luca, are you able to share the slides with us, or
Sure, absolutely. I just have to find the way to do it.
I think if you email either me or Rihanna, we'll find a way to.
I have the
Rihanna
slides,
has it.
don't worry.
Right, Rihanna has it.
Yeah, okay. I think there's also one other question from Sharon in the chat before we move on to our next speaker. She says, how do you get vitals when you have a patient where the burns have spread to parts that you're supposed to check vitals on?
That's a good question. You can't. You find alternatives if possible. Otherwise, you can't. And you know, you always have, as I said, you always have ultrasound that can help a lot with a lot of vital signs. But for SpO2, if you don't have a place where to put your oximeter, you don't know it. It's hard not to have a single part of the body which is not involved, which is not involved by burn. So you normally find a way to do that. You will have a single finger, a single toe that is not burned. So you will probably find a way to do that. Now, I never had that problem of not being able to check any vitals. Yes, of course, sometimes you cannot always check blood pressure on the arm if both arms are involved by burns, but you can check it on the legs. You know that it will be a little different from the one at heart level, but what you need is a trend. It's not a single value.
Great, thank you. I think we have one more question and then we might have to move on. It's from Aaron. How best is burns to the face addressed to ensure airway is open?
Sorry, I missed that.
No, it's all right. So Aaron asks, how best is burns to the face addressed to ensure the airway is open?
You just assess. It's a tightrope, as I said before, when you are in low resource settings, because if you cannot keep a patient intubated because you don't have a system that supports that, the only other option is not to intubate it, and so to keep the head elevated. And normally it's downhill after 48 hours because the swelling goes down, and you have to manage those first 48 hours. So the no touch policy, sacrificing oral intake, NG tube, and calories intake. It's all about not touching the airways, and you can tolerate even some stridor. The most important thing is not touching it and keeping it above the heart level, so it goes away. And if you lose airways, you go for a cricotirotomy. But that's really last resort, because then it's going to be more iatrogenic consequences, because you don't have humidifiers. So you can even do tracheotomy, but then you will not be able to properly ventilate, even in spontaneous breathing, but there's no humidification and no way to do fiber optic toilets or the bronchial or bronchi and trachea. So it's a massive disaster. You don't have to touch them. And then if the question was about how to dress them, it needs to stay in the open air. So there's no way to bandage in. The best way is to keep it open. Of course, with a lot of sulfasalazine on it, but you keep it open.
Thank you very much.
You're welcome.
Thank you, Luca, for your talk. We are going to move on to our next speaker. So I'd like to introduce Mr. Jon Pleat. He is a consultant burn and plastic surgeon in the Southwest Regional Paediatric Burn Centre in the Children's Hospital in Bristol, UK, as well as the adult burn unit in Southmead Hospital, also in Bristol. He's a trainer on the emergency management of severe burns course. He is a passionate advocate of evidence-based practice and has a research portfolio that spans first aid, intra-hospital care, and rehabilitation. Today, he's going to talk to us about the precepts of immediate care of a major burns patient and the first 24 hours of hospital management. Over to you, Jon.
Very much for that kind introduction. Very humbling talk from Dr. Blesi, explaining his vast experience in a limited resource setting. I'm going to talk a bit today about our experience and an approach that's widely documented and taught around the world as set down by the Australian and New Zealand Burns Association, ANZBAR, the EMSB precepts, the EMSB, Emergency Management of Severe Burns schema, which allows you a very systematic, very simple means of assessment. So many of the things I'm going to talk about relate particularly to our practice, but where relevant, I'll hopefully be able to give a few insights to the things that have helped me in situations where high-tech equipment, ventilators, ECMO, other means of carefully monitoring or supporting different body systems aren't available. So Bristol, we're famed for our famous bridge, and we're here in the southwest of the UK. We have a famous balloon festival that people visit from around the world. From a burns perspective, we produced a means of scoring the severity of the burn, the care assessment scale, which is now used around the world, devised at the Centre for Appearance Research and University of the West of England. We've also been involved in creating very exciting little patches which change colour with different bacterial flora as they emerge within the burn wound. They fluoresce with, as you get colonised with staph, Pseudomonas. One for the future, near bedside testing. But we've been around for about 65 years as a service, and we're one of the first burn services in the UK. We're based at 2 hospitals, at Children's Hospital and the Adult Hospital shown below. So why do we need to treat burns optimally? Well, we know from the fantastic research done in Galveston Hospital in Texas that if you analyse the blood of patients who've had major burns, about 2,500 proteins go up, about 1,000 proteins go down, various cytokines and growth factors which affect every body system. This is a transcriptomic chip, which I don't really understand, and these little blue and red dots explain how certain chemicals go up and down in those individuals who've had major burns, and thousands of things that change. It's the insult you get in terms of inflammation from a major burn going around in your plasma, going around your bloodstream, affects every body system. So we think not only beyond the immediate damage to the skin and a late influence on scarring with itch and pain and contractures, particularly in low and middle income countries, my experience, often burns can spend many months before they heal with repeat dressings. That can predispose you to quite severe contractures around mobile apertures, around joints. Those contractures can limit function, have enormous repercussions for those individuals. But it's not just the local effects on the skin, that those 2,500 proteins going up, the 1,000 going down, affect every body system. You get a restrictive lung defect, fibrosis around a lung, you lose muscle mass, your bones demineralize, you get subtle cognitive and memory and concentration effects years down the line, and you have reduced potential to thrive. So the main driver of this is inflammation due to the capillaries opening up to the blood, in the lining of the microcirculation, allowing lots of protein to get out into the interstitial space, and essentially all body systems within that first 48 hours, as Luca has described, become quite edematous. And as you were hearing, sitting patients up, elevating the burnt part is absolutely essential. So the structured approach I'm about to talk about has made a huge difference in terms of prognosis. We now have the evidence that a very ordered approach to the individual when they present in your departments, and a very rapid approach, dealing with airway first, all the way through to disability and the environment around the burn, has a real influence on prognosis. So this over-complex graph shows that prognosis improved with advances in burn care between the 1950s through to 1963 and a later cohort between 1987 and 1991. So it's a percentage improvement in terms of survival by age. So we had the biggest effect on young adults and children, but they're in the elderly population. Even today, in all settings, we still haven't improved things greatly for those older than about 50 years of age. So what is the modern hospital treatment of burns evidence-based? Well, we start at the scene of the actual burn itself, and all of you, it doesn't take much to, most patients, studies have shown this, know when a burning starts, they've had hot oil on them, or they've had a major flame burn, to stop, drop and roll, to limit the access to oxygen, to limit the burning process. Then it's important, once you've removed the oxygen supply, to undertake some first aid to reduce ongoing damage. And we know from analysing burn wounds that limits ongoing heat dissipation to deeper tissue, and it essentially takes away the heat image's effect harmful to cells, so that it allows what are called molecular chaperones, proteins that protect the structure of viable tissue, to do their job. So we now have some really good evidence, mainly due to the work of Roy Kimball, professor in Australia, some work we've done in Oxford, that taking away the heat energy from the site is vitally important. To do this optimally, you don't need to spend any money. You don't need great resources. Static water is not as good as running water. Putting a burnt hand into a bucket of water is not as good as putting that individual's hand under a hose pipe, under a tap, and keeping them there for at least 20 minutes. We now know conclusively that first aid is beneficial up to 3 hours after the burn, and there's some argument that it may be beneficial for up to 12 hours. So starting first aid with running water, shouldn't be too cold because of the vasoconstrictive effects, the stimulation of smooth muscle contraction around your microcirculation to limit upper dermal blood flow, can progress the depth of burn injury and produce more chemicals, which then pass via the bloodstream to cause more distant problems in other body systems. So you only cool the burn, running water, and do it for at least 20 minutes. Warm the patient. Cooling the burn can have serious knock-on effects in terms of hypothermia, and we're about to publish our international study of analysing what clinicians feel is the optimum temperature for keeping the patient in the early period after a burn injury. But centrally, you need to keep the patient warm, blankets, but running water over the site. For chemical burns, for all but certain scenarios such as group 1 metals, certain hydrocarbons, irrigation again, irrigating to the point, if you haven't got litmus paper to hand, litmus paper is often not available, then a key thing, and I often ask my patients after a chemical burn injury, is it still intensely painful? Once the pain is starting to go, it may mean you have to sit them under a tap or a shower for half an hour, maybe longer, before the pain starts to subside and the chemical has started to equilibrate and come out of the top layers of the skin. we're lucky. We have agents such as diphoterine, an amphoteric compound you can spray onto the skin, which has many millions of binding sites and can deal with corrosives, acids, alkalis, and these sorts of chemicals. Once first aid has been applied, it's important to apply a temporary dressing, and you don't have to have any expensive resources for this. As you've heard from Dr. Blesi, for the face, simple paraffin, Vaseline. This acts to lock the exudate in, stops most patients with superficial facial burns will have a high output watery protein-rich fluid coming from their face for at least 24-48 hours. So it's important, as you've heard, try not to touch the burn too much after their first aid, but with clean hands to apply Vaseline alone. We're not such great fans of flamazine, silver-based preparations, because sometimes it can discolor the skin and make appreciation of transitioning of that burn to a deeper burn more difficult to appreciate. But certainly, as you've heard already, keeping the face free from dressings is often useful, but trying not to dry the burn out for more superficial burns. Simple Vaseline applied regularly 2 or 3 times a day is all that's needed. For other sites, keep it simple. Saran wrap or cling film helps to lock the moisture in, prevents evaporative losses, prevents air currents causing pain to the patient. Important with transfer to keep it simple. It is also simple to remove and causes less pain than putting a gauze dressing on the site. Elevation is vital, elevating the part that's been burnt, because that can prevent a limb which has mid-dermal to deep dermal burns, and I'll explain this in a minute, from progressing to a full thickness burn in the 7 hours, 12 hours transport that patient may have into your service. So strict elevation of the limb is vitally important because it may save that patient, necessitating what may become life-saving surgery. So we're grateful for the ANSBAR system, which has been present for at least 20 years, it's very much similar to the acute trauma life support system or the acute cardiac life support precepts, the system, because it gives you an A to E, A to F of measures that you should take to ensure that the patient, once they come through your emergency department door, these are the things that are going to kill them sequentially. So you deal with the most important and life-threatening elements of the injury first before you deal with less vitally important measures. So primary survey and secondary survey. So first you worry about the airway, and you've heard some sensible advice from Luca a moment ago. I would say that a really useful thing when it comes to assessment of really horrible cases, as you can see here, is that often the history before they even get through your doors will give you half a clue to how concerned you should be. But flame injuries in enclosed spaces, significant evidence of a person trapped in a burning car, smoke enclosed building, you've got to be worried about not only an upper respiratory injury, but significant heat and chemical injuries to the lower respiratory tract. So if they have difficulty speaking to you, dysphonia, they've got a hoarse voice, sooty sputum, evidence of facial burns as the patient on the right there, difficulty breathing, and the obvious thing, tachypnea, low sats, then you need to think of measures to immediately protect that airway. And those might include a chin lift, using pressure on the apex of the mentum to lift the chin, the mandible, away from posterior structures, in essence lifting the tongue from the posterior pharynx to allow the patient, if they've still got respiratory effort, to get oxygen into their lungs. Simple adjuncts are useful, because if you haven't got the means to intubate and ventilate, then things such as nasopharyngeal airways, nasal airways, or basic oral airways, are vital for that first 24 hours or so, unless the patient is, is choking, gagging, the vagal response. There's a risk of aspiration due to vomiting. So yeah, sometimes you're in a really difficult situation because some of the things you want to do to protect the upper airway may cause other problems. You don't necessarily want reflux issues and things going, your contents of your stomach going down into your lungs and causing a massive secondary pneumonia. So securing the airway may be difficult. One thing we've found useful when we've been up against it is using nebulized adrenaline solution at low concentration, which causes upper respiratory tract relative constriction, not to be given, obviously, if there's any evidence of bronchospasm, to be absolutely cautious with this measure. And it's not something we would do standardly, but it's a measure if you're really up against it and you're worried about facial swelling, upper airway swelling. The most important measure is to keep that patient relatively elevated, the head as upright as you can, and a high flow of oxygen if you've got it. In terms of circulation, we've done airway and breathing. We're checking peripherally. That was that really useful question a moment ago about how do you monitor these patients? Well, if you haven't got an ultrasound machine, as we've just heard, if you've only got a blood pressure cuff, then certainly you can think about calf pressures and the trend on calf pressures. But if the patient's sitting up and talking to you, their mean arterial pressure is enough to perfuse their brain, and that's a reasonable index that they're getting systolics enough to keep their vital organs alive. You're constantly reassessing them to see if they've got a good peripheral pulse, if necessary, going to carotid to make sure that they've got a decent pulse there. If they you can't get a peripheral pulse due to them being shut down, or because you can't get access to the radial artery or groin because of the burn. But you need to assess those patients if they've got a circumferential and deep burn as to whether they might need an escharotomy or a fasciotomy. For those of you who don't see burns regularly, escharotomy means cutting through a circumferential deep dermal or full thickness burn on a limb or the torso to allow the blood to flow adequately on the former, to allow the lungs to the bucket handle, the rib excursion, to allow the chest wall to elevate to get oxygen into your pleural space, to have negative pressure, get oxygen to your lungs. So escharotomies can be a life-saving procedure in the moment the patient comes through, and it's a talk in itself, a conversation for another talk in terms of planning. But your surgical colleagues should be well versed with regard to escharotomies and fasciotomies to relieve pressure on the deeper tissue. But the key thing for you as you assess the patient through the door is just to ask the question, have they got a deep dermal or full thickness burn with evidence of peripheral compromise? Is for a circumferential deep burn on the upper limb, is the hand cold? Are they pulseless at the wrist? Have they got no capillary refill? Have they got paresthesia in the hand? So all of these, you immediately ask your surgical colleague to attend, and it might mean the immediate release of the skin to allow adequate blood flow. So we've done A, B, and C, circulation. We move on to disability, neurological status, where you don't necessarily need to do the Glasgow coma score. In the heat of the moment, you needing to assess the patient urgently, we tend to revert just to whether they're alert, vocalizing, they're talking to you, even if they're confused, means they're perfusing their brain, whether they're obtunded, whether they're not really responsive, but only responding to pain, or whether they're significantly more obtunded and they're unresponsive. A GCS, if you are going to do a GCS of 3 or 3. So the unresponsive patient, immediately you're concerned about the risk of distributive hypovolemia, the fact that the burn is so severe that they've lost a significant circulating volume, they're unable to perfuse their heart and vital organs, and you need to urgently assess that patient in terms of going back to the top of the tree, airway, breathing, and circulation. We also assess the pupillary response, but just once in a while we have patients who, for example, explosions or jumping out of buildings, who've had a major head injury, and as the subdural at the top there, these patients need assessment with regard to potential intracranial injury. After disability, we look at exposure, we remove all clothing and jewelry, we log roll the patients to make sure we don't create a secondary iatrogenic secondary injury to their cervical spine, and creating a severe neurological injury, and we aim to keep them warm, because by doing all this assessment, frequently the patient's exposed for long periods of time. Fluid resuscitation is vital. We get 2 large bore intravenous lines, ideally through unburned skin. But if this isn't possible because they've got such a large burn, then once or twice a year I'll do a cut down at the ankle to find the long saphenous vein and get some access in there. Sometimes when you're up against it, and I have done this occasionally, for children, I might use a scalp vein or use a central vein, sometimes looking blindly when we've got no access at all and we haven't got an intraosseous needle to allow us access to the anterior tibia or the top of the humerus. So when you've got limited resources, you just have to make do with what's available, and that may mean getting lots of large lines in places you don't necessarily want to get lines into because of the presence of the burn. Big access is important. Then the key things that we've learned back in the 70s to the 90s are that early fluid resuscitation saves lives. So you need to assess the total body surface area that's been burnt. There are a number of means of doing this, such as the London Browder chart, and you can look on Google to look these up to give you approximate body maps. So each part of the body has a relative percentage of that individual's total body surface area, and using those maps you can work out roughly from the patient in front of you how much of their total body surface area, TBSA, has been burnt. And that gives you a guide as to how much fluid, according to the calculation I'll show you in a second, you should be giving them. Alternatively, you can do the rule of 9s, where each body part, an upper limb is roughly 9% in total, the lower limb is 18%, the front of the torso is 18%. The rule of 9s works, or alternatively, the patient's hand is 1% of their TBSA. So you can use the patient's hand as a guide. Here's the London Browder charts, but you can just look them up on any on the internet, but they give you a guide to TBSA. You need to know roughly what the weight of the patient is to guide your fluid resuscitation. This must be in kilograms, in kilos. You can use a Broslow tape if you've got one of those available, or for children particularly, I tend to guess. We're using the age up to the age of 10. 8, that's the age in years. I add 4 and I multiply that sum by 2 to give an approximate weight of the child. So using the weight and the TBSA, with you looking at the patient in front of you, the fluid you should give them in 24 hours is somewhere between 2 to 4 mils of any crystalloid, any isotonic crystalloid. So crystalloid is important because of sodium, potassium, chloride, calcium. It's important because this fluid maintains their intravascular circulating volume. It means their circulating red cell mass delivers oxygen to where it's needed most. You give half of your total calculated fluid volume in mils over the first 8 hours. You give the remaining amount over the next 16 hours. So a calculation, a real world example, 15-kilo child comes into your A&E department. You've calculated using the London Browder chart, the rule of 9s, or the 1% size of their hand, that they've got about a 30% total body surface area burn. And you start off conservatively with your bag of fluid, your bag of crystalloids, things like Hartmann's, or plasmolite we sometimes use, and you aim to give that total volume, which is 15 times 30%, 15 kilos times 30% times 2 mils per kilo per percent, giving a total of 900 mils for that first 24 hours. You give the first half of that in the first 8 hours, and the remaining half of it over the next 16 hours. So 450 mils over the first 8 hours gives a rate of about 56 mils an hour. It gives you a guesstimate. It gives you a rough estimate of what you should be doing, but it's just an estimate. So you need to monitor, because there's a real risk that if you overdo it, they'll get overload. That facial swelling that Luca was talking about will get worse. A constrictive deep dermal or full thickness burn on a limb will get worse, and they'll get restriction distally, or they'll get compartment syndrome, ARDS, SIRS. Conversely, if you don't give them enough intravascular crystalloid, the circulating oxygen won't be enough, and oxygen delivery to the target organs won't be adequate, and they'll become ischemic, and their burn will progress, and they'll become more sick. So fluid resuscitation is vital. When might you give more than 2 mils per kilo per percent? Well, when you have crush injuries, with the patient giving either urinating every hour, or more commonly with a catheter in. Catheter is absolutely vital with bigger burns. We put one in when the patient has more than a 15% TBSA burn. But any of the situations you can see on screen there, they're going to be putting out more fluids into the interstitial space and through the burn, being lost by insensible losses to the surroundings. So you might need to increase the fluid rate to more than 2 mils per kilo per percent. And with your urine output being your arbiter, your index of whether they're adequately perfusing their end organs, you're aiming for about 0.5 mil per kilo per hour to 1 mil per kilo per hour as your target fluid output. And if they're not reaching that, you either give them a bolus over the next hour of 50% of what they're due over the next hour, or a 5 to 10 mils per kilo bolus. And you look again. Handy thing we found in the UK, and it should be present on the Android store and the iPhone app store. There's a very simple app that's by the team in Liverpool in the United Kingdom, the Mersey Burns app, which allows you to draw in real time the size of the burn of the patient in front of you with your finger, whether it's partial thickness, it's just the top layers of the skin, or it's deep derm or full thickness, and it will calculate the fluids for you. So it's a very simple help in an emergency situation to guide your immediate management. It's called the Mersey Burns app. I think you don't have to pay for it. I think it's free, and you just have to register. Then back to the monitoring question we had earlier. Sometimes all you've got is pulse and blood pressure, and that's a start. You don't necessarily need more complex means of monitoring, and as Luca said earlier, the trend is vitally important. Feeding, we do like to, because we have the luxury of all the things that allow our patient ICU care. So we'll often get a nasogastric tube or a nasovaginal tube down early. Some really good evidence from around the world now that if you start feeding early, it protects the mucosal lining of the small bowel, stops your biome, your bacterial flora within your gut become translocating, moving from the lumen into the bloodstream and appearing at distant sites to cause problems in the wound and distant sepsis. So if you can keep the integrity of the gut working by feeding early, you don't have to do nasogastric or nasovaginal tube feeding. It may not be available in resource limited settings. So just encourage that patient to feed when you feel they're able to. And pain relief, as you've heard, is vitally important. And burns are horribly painful, so opiates are vital. We tend to use intravenous morphine in small aliquots, small little, according to weight, and we titrate every 20 minutes, every hour, until their pain score out of 10 is coming down. But we will also use use paracetamol and more simple analgesics to work on different parts of the pain pathway. We've got a couple of techniques at the bottom there which we found to be useful. Lastly, we take a history from the patient and the relatives or the team that brought the patient in to guide what we might do next. And what that helps me as I plan to take the patient to theatre, knowing if it's safe, knowing if their past medical history is going to influence whether they can be anaesthetized, whether we need to do early surgery according to the nature of the injury. And we mustn't forget, in our head-to-toe examination at this point, of concomitant injuries which can put that patient at risk. Very quickly, it's vital to assess the depth of the burn. Once you get beyond the mid-dermis, the bottom area of the skin, the mid-dermis, those burns are going to take months to heal. Constant risk of your colonizing organisms in your sweat glands, sebaceous glands, hair follicles, colonizing the burn and becoming invasive and making that patient really sick. So deep dermal burns and full thickness burns, really good evidence from places like Galveston again, the early excision, Zorba Jansekovic in the old Czech Republic taught the world that early excision of deep dermal burns and full thickness burns saves lives. So if you've got a burn that goes through beyond the threshold depth of the mid to deep dermis, you need to excise that burn, and you need to assess the burn, whether it's superficial, it's just an epidermal injury, usually without blisters, painful, but usually not wet, usually dry. In skin types 4 and above, darker skin types, usually the only clue is significant pain and induration, but no blistering. Beyond superficial burns, as this poor gentleman here, the barrier function isn't lost. If their whole body is affected by a significant superficial burn, a major sunburn, for example, you might require to give them a bit of fluid resuscitation, encourage them to drink isotonic fluids, and also give them some adequate analgesia. But we don't worry about superficial burns. Slightly deeper superficial dermal burns affect not just the epidermis, but the top of the layer beneath. And these are characteristically, in all skin types, start to show blistering. Sometimes in darker skin types, there's graying of the pigment or lightening of the pigment. Beneath with a thorough cleaning of these burns to remove blisters, the skin beneath will appear pink to white. There's good blood flow when you press the skin. They're horribly painful. These patients need lots of analgesia, and they typically heal within 14 days. These patients don't need surgery. Unlike deep dermal burns, the next layer down, as I've said, the injury here causes release of chemicals that make distant systems unwell, causes major problems in your heart, your lungs, your gut. So sometimes you've got no choice. Sometimes when you're overwhelmed with casualties, as we had a few weeks ago, you have to temporize, and some of these patients get treated with dressings for weeks. And what will heal slowly, but some of them will go on to require surgery. But the clue for this group is that sensation is altered. It's usually not so painful. They'll get deep pressure sensation, but it won't be anywhere near as painful, and it's often a lot drier. And in darker skin types with deep dermal burns, the skin looks much whiter and dry. Finally, full thickness burns are usually very easy to determine because it's almost it was described to me many years ago. It's like a fried egg. You've denatured the proteins, everything contracts to a point. It's hard, it's dry, there's no sensation. And these patients, unless they're small areas, less than 1%, will often require surgery at some point to resurface before the burn releases that cytokine storm, all those nasty chemicals, that proteins, to make them significantly sick. So hopefully I can send you that over complex slide a bit later but I'm sure a lot of you have got vast experience assessing burns by depth. Finally, I work with 3 teams of psychologists. I'm very lucky. These are horrendous injuries. I was burnt as a child. It got me interested in burns. But it's interesting, the effect on me was mild, but the effect on all of those around me was feelings of guilt, feelings of anxiety, how the acceptance, how that individual reintegrate into society. All those influences are vitally important and mustn't be forgotten in the heat of the moment. The burns can be devastating. So I've gone on too long. I do apologise. I'm very humbled to be invited to talk today. Key points: first aid is vital. Running water for at least 20 minutes. It works hours after the burns happened. The ANZBAR, Australian and New Zealand Burns Association precept scheme of emergency management of severe burns, EMSB. There's an A to F system which gives you some practical measures of assessment. Really important to keep going back to the patient. So if you start fluid resuscitation, that you know it's working by looking at the urine output, 0.5 ml to 1 ml per kilo per hour. You don't really need any fancy machines or equipment in that first hour or two to ensure safety. But as Luca said earlier, sitting patients up, ensuring nothing's constricting the site, avoiding handling of the burn too much for risk of contamination, giving the area a good clean, vitally important. All the fundamentals, and don't forget the psychological issues as well as the physiological issues. Thank you for the opportunity to talk today.
Thank you very, very much, Jon, for that talk. Very interesting, really informative. If we've gone a bit over time, but if anyone had any questions, please ask away on the group. I actually had a question about the psychological aspect behind burns. I think that's really interesting, not something that I've actually personally thought about that much. How does it work in terms of like how long do people get follow-up in terms of that? Because it must be a very long-lasting psychological burden.
Really good question. So for children who come to us, they'll often have support. We're very lucky with a psychologist right until they get to the age of 16 to adulthood. For those individuals who come back to us as adults with burns and something has changed in their life, that they completely accepted, change in appearance, change in body image, something changes in their life that suddenly they become very anxious about appearance, or they've had teasing or bullying. We've got the advantage of an adult psychologist who can work with them to give support. So sometimes the effects of a burn can be very subtle. The Centre for Appearance Research here in Bristol has shown that even quite minor burns that aren't visible can have profound effects on an individual for their entire life, such as even though most people will never see those areas of scarring, it's perceived by the individual who's been burnt that they've had something which means they can't leave the house, that alienates them from friends and family. So you'd be surprised. Sometimes quite small burns can have very profound effects.
Oh, really interesting. There's one question on the group. There's what are the indications of PPI and antibiotics in burn injury?
So PPI, proton pump inhibitors to reduce acid load in the stomach. There's been a real move away from them because we're associated with higher risk of aspiration pneumonia. My anaesthetic colleagues and intensivist colleagues will be able to give a more of a background to that, but we don't give PPIs as standard to all of our patients. If they've got a significant history of reflux disease or hiatus hernia, then we might reconsider that. In terms of antibiotics, really important antibiotic stewardship. We've got a Armageddon coming. There's a real problem we're seeing with multi-resistant bacterial organisms coming to us, Pseudomonas, Acinetobacter, which are resistant to almost every drug we have. So we don't tend to give antibiotics to any patients other than those that present late with significantly contaminated burns or evidence of cellulitis or erysipelas or systemically septic at the door. So we are fairly stringent on trying not to give antibiotics unless we absolutely need to.
Right, thank you so much. I think that's all the questions. Oh, sorry, no, I think I missed one. Oh, so Olas asks, how are complications managed, especially contractures?
Talk in itself, very dear to my heart. As a plastic surgeon, let's not forget the fundamentals when the resources aren't great. Significant contractures, it's possible with serial splinting when they're not too severe over the space of many months with plaster of Paris or thermoplastic splints to regain some of the range of motion. But for significant contractures, often a surgical release is the only way to allow you to regain range or for around the oral commissures, to allow freedom of motion, to allow the patient to oral competence again, to keep food in their mouth. The other one we see regularly is significant contractures around the orbit causing ectropium exposure, keratitis, blindness. So I'm very happy in 6 months' time to come back and give a talk on treatment of contractures if that helps.
Yeah, that might be a lecture on itself. We do have one other question, but unfortunately, I think we do need to close up now. So thank you very, very much for both our speakers for coming and talking to us about burns and their experience. Then thank you for everyone who's participated and asked questions and come along to learn and listen. So our next talk for our Global Health Grand Round will be Wednesday, the 9th of July. So we've posted a feedback link into the group, which I think some people are having slight trouble opening. Let us know if it's still not working. And there is also a WhatsApp group where we post the different talks that are happening each month. We've posted that on the group as well. We also have a link in the description of that WhatsApp group. If you are interested in speaking on our next Grand Round, we're very open to different topics. Please let us know. That'll be great if anyone could also join. So again, thank you very much for Jon and Luca for joining us and informing us of the different managements and their experience. Yeah, thank you very much, everyone. We appreciate it.
Thank you for the invitation. Bye-bye.
Thank you very much.
Thank you. Bye-bye.